So you guys all drew the short straw and got me twice in a row, so apologies for that. So my second presentation today is going to cover step 9 and about submitting annual reports to the community. And there's 3 parts to this presentation, the why, the what and the how. So let's start with why. Why do we submit reports to the community? And especially if out-of-hospital cardiac arrest is such a small proportion of our total EMS workload, and in some cases it can be less than 1%, why do we focus on out-of-hospital cardiac arrest? Well, as you all know, universally, survival from out-of-hospital cardiac arrest is low and less than 10% internationally. So there's heaps of room for us to improve. And as EMS, we have a predominant influence on outcome, as out-of-hospital cardiac arrest is one of the most time-critical, time-dependent conditions. And it has a measurable outcome, which is mortality. And more than that, if an EMS has high survival rates from out-of-hospital cardiac arrest, then this is also a surrogate for high performance in other areas. And an annual performance report is the best way for ambulance services to declare accountability to the community for out-of-hospital cardiac arrest survival. Accountability is our commitment to account for our activities, accept responsibility for them, and disclose results in a transparent manner. And in terms of out-of-hospital cardiac arrest, this means that we're accepting responsibility that our activities impact on survival and taking responsibility for this through disclosing our survival results. And with this commitment and responsibility, this can lead to the development of internal key performance indicators and organisational targets. And this linking to performance can lead to support, funding, resourcing to enact changes that will likely increase rates of survival. We also do this as a way of comparison. Publishing our results to the community enables other similar services to compare their outcomes with ours, and vice versa. Through making comparisons, this means we can look at what other services might be doing differently to obtain better results, and we can emulate those in our own services. In competition, well, who doesn't want to be the best? And by publishing our results and comparing to others, this definitely is a driver to improve outcomes from out-of-hospital cardiac arrest. What are the risks and benefits of such transparency? Well, this is what I call a win-win. It promotes the organisation if the results are positive. And if the results are not so positive, then the information can be used to motivate internal and external stakeholders, including community leaders and politicians, to invest in efforts to improve. And some examples of this will be shown over the next few slides. The first example of this was when we released our first report in 2014, and we had this stunning headline in the paper that St John's cardiac arrest record outstrips our global counterparts, which was quite fantastic, being that was my first cardiac arrest report. A second example of this was when we had the headline that the out-of-hospital cardiac arrest report also found Māori to be disproportionately affected, with 40% higher chance of having a cardiac arrest than other ethnic groups. And although this is quite a negative finding, this drove funding for AEDs in Marae. Another example of this was when survival rates from out-of-hospital cardiac arrest were compared to the New Zealand road toll. Again, a negative result, but this was used as a driver to start our 3 Steps for Life program, the free CPR and AED awareness community program. The last example I've got of this win-win was a negative headline regarding our poor rates of community AED use. And this was also used as a driver to purchase AEDs in the Hawke's Bay community. So now we move on to the what. What do we do? We generate reports, and importantly, we make these reports readily available to the public. We don't just keep them to ourselves, we make them readily available. And in our case, the last 4 years are available on our external website on our performance tab. And they're PDFs, so you can all go on there and download them and have a look at how we're doing compared to you guys. And what's covered in an annual report? For those of you who are just kind of starting out in this, what do you need to actually report on? Well, it'd be really nice if you introduce your service. For example, what's the size of the population you serve? How many cardiac arrests do you attend every year? What's the makeup of your staff? Are you all intensive care paramedics? Are you all paramedics or EMTs? And what's your usual protocol for responding to cardiac arrest? Do you always co-respond fire? Do you have a one-tier response where you just send ambulance? You'll also need to describe your registry and how your data is collected. For example, is it electronic or do you have paper records? Who's included and who's excluded? And you also need to show some evidence of ethical review. There's some controversial kind of points of debate. So, for example, how do you and your organisation define what a resuscitation attempt looks like? In New Zealand, we just define this as the performance of CPR by or under the direction of responding personnel, or the delivery of a shock at any time, including before ambulance arrival. However, should we include all of these patients? Perhaps we should only include those where there isn't a premature cessation. For example, patients where a resuscitative attempt may have been started, but has ceased early when the patient is found to have a history that would make it inappropriate to continue. And whether or not you include patients presenting with ROSC, and I think Tony touched on this the other day as well, who were defibrillated prior to ambulance arrival. In our service, we include these patients within our statistics, as we believe they've survived because of the system of care promoted by the ambulance service. However, technically, they were not physically resuscitated by ambulance staff. And whether or not you include ambulance officer witnessed events, we don't include these within our survival statistics. However, this is only to align with other services. However, it could be debated as to whether we include them because the patients are still being resuscitated by ambulance staff. And these patients are again representative of the system of care, including health promotion, which may have led them to call an ambulance for chest pain in the first instance. And whether or not you limit the Utstein criteria by causation to those with a cardiac cause, or you include all events. This is debated because the cause of cardiac arrest may not be determined accurately by paramedics in the field, and we just presume that they're cardiac if the cause is unknown. And there's obviously more points of debate than just those that are shown on this slide, but the last one I'll touch on is survival to 30 days or to hospital discharge. And there's also debate around this because sometimes patients are discharged into hospice care where they subsequently die. So what do you actually report? Once you've decided what you're going to do about those points of debate, what do you report on? Well, there's 3 points that you should try and report on. These are all cases, the Utstein subgroup, and the 10 steps to improving survival. When you report on all cases, we include adults because paediatrics are quite a different population, and we include all cases with a resuscitation attempt regardless of the cause of that. And we exclude cases that are witnessed by ambulance staff. And the 2 outcomes we report on are ROSC, sustained to emergency department handover, and we in our service report on survival to 30 days, but your services might report on survival to discharge. The other group that we report on is the subgroup called the Utstein criteria. And these are, again, adults where resuscitation was attempted. And in our case, they're all cause. And they're those patients that present with a shockable rhythm. So immediately they're our most survivable group of patients. they're bystander witnessed. And again, we exclude those cases that are witnessed by ambulance staff. And our two outcomes are ROSC sustained to emergency department handover and survival to 30 days. And the last thing that it's really great to report on, and we've only just started doing this in our service, is the 10 steps to improving survival. And whilst measuring the 10 steps can be slightly subjective, you can, in the interim, provide a narrative under each of these steps for your own service, which can provide a roadmap for future improvements. Now we move on to the how. The how is all about networking and collaborating. For example, attendance at this resuscitation academy, developing co-join positions with your local universities, joining collaboratives such as AusRock or PAROS, and asking those who have already produced reports for guidance and support. Recruit volunteer researchers if you're unable to fund positions. This is a really interesting project for people to get their teeth into, so approach your local universities. And I don't have it on this slide, but you need to resource an appropriate amount of time to do this. And even with our established registry data available, it still takes us at least 12 weeks to put this together. And lastly, but absolutely not least, don't just start. Don't wait for the perfect registry data. There's actually no such thing. And don't wait to have 5 years for comparison. We started with 9 months of data. And don't wait to have complete survival data. If you can only get ROSC sustained to hospital, report on this if that's all you've got available, because then you at least have a starting point on which you can improve. So I've covered the why, accountability, comparison, competition, and the win-win. The what, we need to make these available to public. And what you include in your report, or would like to see in your report, you want to introduce your service, describe your registry. You're going to have some debate around your definitions and inclusion. And you want to talk about your outcomes in the 10 steps. And how, it's all about you guys, collaborating and networking. And you just need to start. Thank you.